Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory of the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist. I'll be your moderator today. We would love to hear from you. This is a communal reunion, so please send us all your questions, either in the PubMed or directly on our website. And remember, all these cases can be seen in our website, ccclifecases.org. We have a fantastic case today, so let me transfer you to Dr. Kinney and Dr. Sharma directly from the cath lab.
All right. Good morning, Pedro, and to viewers of our CCC live cases, and particularly structure live cases today. We always try to show very interesting and the new case. And actually, I thought there's not much interest in the structural cases, but we saw many of them. We have 6,000 to 8,000 hits per month, as long as it's a new interesting case. And this is, I hope, this will be in that category. Myself, Dr. Keeney on my right side, Dr. Tang, Dr. Khera, and then we have our few fellows here with the Penta and the Nana Toda. We actually have the surgeon who was trained as the structural fellow also and graduated and got a nice job as a structural attending, cardiothoracic attending, Oklahoma, and we have our rest of the staff. So with that note, let's start presentation of this case, which is usual our supporters. These are the faculty. Our cardiac anesthesiologist is Dr. Ran Khan, and he'll keeping the patient with a conscious sedation.
No, this is T.
T. Okay, so T, this case we did. You know, it's sometimes better to have a T, particularly during these live cases, and more importantly, if you have an issue about the valve, where to position so the hemodynamic remains stable. Now, so this is the case of the Redo-TAVR. So people call TAV and TAV. I think the common terminology now coming up is the Redo-TAVR for significant PVL using SAPIEN-3 Ultra Resilia and left main protection. You say, well, why significant PVL? PVL happens acutely, and that happened, of course, later on also. And this is very unusual case because this happened within 1 year. This is our episode number 60. So we knowing that we do 2 every other month. So this will be the 10 years. Now this is the 10th year for our structured live cases. So it's 88-year-old patient had us presented with NYHA class 3 and fatigue. Patient did have the 23-meter SAPIEN Ultra TAVR on May 16, so about 15 months ago at outside hospital, and has various risk factors which shown there. Ejection fraction is normal, and echo revealed moderate to severe PVL. While the leaflets were good, and there was very minimal gradient, which you expect 10 to 12 only. Good medical therapy, and we'll just go through that non-obstructive CAD. So I think most important in this case is why this patient come back so quickly, and if we can show the echo. Actually, you know what, before we go to echo, let's wait. And Gilbert, actually, we were able to get hold of those three-tower CTA on this case. This is right. 15 months ago.
So you can see that the initial valve was appropriately sized for the, say, 23S3. It was maybe a little undersized, but still within range. But you can see the LVOT is big. It's almost a 26 range. And then when you look at the STJ, you can't really oversize because the STJ is small. So probably the heart team at the other hospital say, well, we better not rupture the root. So we have to go for 23. I don't know if they added volume to the procedure, but you can see also the left main is quite low. So that's another reason why they probably picked the 23S3.
Right. So let me ask you, let's say we are here, May, you know, Back to the Future, and we are in the May 1623. So what we will be knowing that what happened to this patient within 15 months, what we would have done differently at that time? Anything we can say?
I mean, if this were done, you know, here, I think we wouldn't do anything different. I think we maybe added more volume to try to make sure there's no PVL left at the end of the procedure. And, you know, I think that's one area that we would have to maybe monitor more closely.
Okay, because this is very good point. Coronaries, where you see it, they are normal, very low height. This is the
initial aortogram.
Initial aortogram. See the leaflet? It's just below the left main.
Yeah, you can see the bubble. That's why we protected in the first place.
Yeah.
Yeah.
So this is this was the patient had a sorry, echo. They were still behind. We are last year, EF of 30, mild PVL was left. Sorry. So question is, nowadays even mild is too much for us, right? I mean, we try to get a minimal, maybe a mild. Sometimes we leave with a self-expanding, with a balloon expandable. We sometimes go with an additional CC or just a second inflation. So this case had a mild PVL at that time, and then of course at 30-day had a still remain, and then there was a gradient of about slight increase, which we normally see, and until immediate post-procedure, and the 30-day PVL remained the same, but ejection fraction improved. So that basically means something good was done for this patient. Now, then the 1 year later, this is about actually 13 months later, now the patient presented with this. So we can comment on this, and then we'll go live.
Yeah.
So this
Sam, you want to comment on this as our echo person?
Yes. So you can see that this the PVL there is at least moderate. From what we can tell is limited views, but for sure more than what you would like to see, and is
okay.
Moderate to severe range. Normal function. I don't know if it's any other views, but
yeah, and particularly the gradient was just say about 10. It was 10 to 12 at 30 days, remain at 1 year about 12, and the valve area like 1.4 and so, and you can see from the gradient point of view. So this is now, then there's the transesophageal echo. Now you want to comment this?
Yeah.
You want to show live, Stan?
No, not I'm going to go live now. Yeah.
You want to show live? Yeah.
Okay, so better we go live now.
Yes. Good morning. Thank you, Dr. Sharma. Good morning from New York. I have with me Dr. Fortis, our imaging structural fellow, and Hafizur, a great sonographer. As you can see here, this is deep gastric, normal LV function, no pericardial effusion. Another view, long axis of the ventricle, looks thickened and normal function. This is the mid-esophageal views, normal LV function, normal RV function, minimal to mild tricuspid regurgitation, mild, minimal to mild mitral regurgitation, left lateral appendage clean. And now here we are in the aortic valve. As you can see, the paravalvular leak comes from most likely an open cell and comes around the valve, as you can see here.
Mm.
It looks like a gap, right, Stan?
Yeah, it looks there's a gap.
Yeah.
The valve is not or under expanded, or as Gilbert said, that is the LVOT is big, so and the valve is small, so there's a space between the valve and the LVOT. The vena contracta is 4, which is in the moderate range. And here is X-plane of the PVL
right there.
and the short axis. And we measure, just to be more accurate, is 11% compared to the frame of the valve, which also consisted with moderate paravalvular regurgitation. This is the left main, as you can see, actually with the bifurcation. You can see very well with TE. And this deep gastric, no valvular regurgitation, all PVL with a gradient of 10 peak and 6 of mean. Thank you.
Okay, so
let's go back to the TE.
Yeah.
You mentioned the frame. Remember, the frame is not well expanded at the level of the left main. Go back there.
Mm-hmm.
I know you mentioned the LVOT was bigger, the valve was smaller, that is further down, but see where the paravalvular leak starts.
Yeah.
Just at the top of the frame. So just by balloon expansion, right?
Yeah.
Yeah, if
We may obliterate that.
I think this is a very classic example of nominally expanded valve in a large annulus. This is what appears to me. And what happens in these patients who have persistent PVL, the LV and LVOT tends to dilate. So initially you had mild PVL, and now this patient comes with moderate to severe. You have recoil in the valve, and you have the LVOT, which is persistently dilating. Although a little bit, it causes more PVL. So that's what I think is going on.
No,
here.
but what Gilbert's point was that LVOT was larger even in the first. So it may be that PVL started there, but this is definitely recoil.
Yeah, there's some recoil. There's a gap. There's a gap. I think Stan shows nicely. So with time, that I think with the very bulky left cusp, then we have seen some of those, and we actually had to brought them back for post-dilatation and sometimes even put a second valve in if it's not sufficient.
So that could be the cause, that the bulky cusp is making it recoil, the frame.
Yeah, I think, to my opinion, I think always can balloon and expand the frame to obstruct that LVOT, so to obstruct the PVL of coming, or the beginning of the PVL.
Yeah.
To seal that area with a new valve. I think this is another
correct
way to do,
So that is why important for the sizing of the valve. No, you remember we are discussing 23 versus 26. I don't think 26 is the answer here.
That's correct. Yeah, that's why we had to use 23. There's no choice.
It has to be 23 and fully expand it.
Yes.
Expansion before, so that that frame is fully opposed, and then put the same size 23 again.
But that's a very important discussion for the audience, right? Nowadays, people doing minimalist TAVR, no echo, no nothing. That's not the right approach, especially young. This patient is obviously not low risk, but a young low risk patient, you have to get a perfect result before. Otherwise, you may come back with this kind of situation.
Yeah.
Now, for completion's sake, why not PVL closure in this case? Just for completion of management of PVL.
Yes, Dan, what do you think?
This would be almost impossible to close, to close with a PVL device, because you have to go in the valve, It's,
no, not even that. It'll obstruct the left main.
I don't think you can do it.
Correct. So these become really challenging.
And we'll show the aortogram because there's no room from the sinotubular junction to go around the valve to go into the LVOT to close it. You have to go through the frame extension. That can compromise the valve function. Because remember, the valve actually is working. It's the paravalvular leak that's the main issue.
Yeah, that's true.
And the patient is actually more progressively symptomatic despite improvement in LVEF. And we'll show you on the CT that the LVOT was in fact a little smaller. It's still big, but actually smaller than baseline that we got. So
okay. So the very good discussion, Pedro, as you saw, a challenging case. Somebody who comes back.
This is also the point comes, Dr. Sharma, when we are dealing with young patients, 67, 72, 74, and lifelong management. Remember, we are talking the proper placement of the valve and the proper selection of the valve. This is, I think, this falls into that.
Then good, that's a good. So that's part of the discussion. Would this patient benefited with a self-expanding valve because of the skirt shape design?
Well, the challenge with such a big LVOT, if a big LVOT in a low left main, it's going to be harder to protect the left main with a self-expanding valve. And also there's a risk of diving, and you actually, because self-expanding weight relies on the passive expansion, you might actually have more PVL. So in our mind, I think a balloon expander valve with this kind of anatomy give us the more predictable result. I think definitely in average hands in terms of the predictability.
Should we have placed it lower?
I mean, that's a very good question. I mean, it's probably now it's going to make the intervention harder. You're right. So we'll show the CT.
I think it is so interesting, and lot of time, effort had to be placed. I mean, put attention into the first procedure.
Yes.
Because we know they're going to come back to us at some time.
And also Navitor wasn't available back then.
Correct.
Okay.
So,
Pedro?
So for the audience, the natural history of these mild PVLs, what percentage of them will progress into moderate or severe symptomatic? That will be the first question.
No, that depends. Remember, he has discussed the various things. He was talking that it could have been mild, and recoil happened because of the bulky leaflet. Then it from mild progressed to moderate, and then the LVOT started dilating, and it just became a vicious cycle.
That's right.
Understood. But we approach, let's say, 10-15% of these, or is it 50%?
Well, Dr. Moreno, that's a great point. In TVT registry, the mild PVL is still around 10 to 15%. So we don't know. I mean, remember, it's only 1 year. There's no longer-term follow-up of these patients. Now, having said that, the Evolut data has shown that with 5 year, the 4 year, the low risk, that the PVL does improve. I mean, that's encouraging, at least for the self-expanding valve over time. But, we don't know about the longer-term follow-up with the other patients. And now low risk with partner 5 year, we also seen that the PVL looks stable. At least these are highly selected patients, right? These are not real life patients, so in terms of the real world. So again, we need to be circumspective about this.
Yeah, if we call it, let's say, underexpanded, or let's say recoil, both of the two terms may be applied. What percentage would you do balloon, and in which you actually start with putting a new valve?
That's a very good point. So I think this is the kind of case, we had a clear discussion on this case. So key is knowing that it's a two-sided, the multiple, the orifices of the PVL. One at the level of the left vein, above supraannular, then infraannular. Their balloon dilatation will help in the upper one, but not in the lower one.
Yes, yes.
So that's why we have done some cases of this, whether it's a self-expanding or balloon expanding, just do a BAV and decrease it. So in this particular case, we all felt that the just balloon dilatation will not be enough, may decrease it, but we don't want to go to the same situation what this patient had. Mild at the baseline and come back in 15 months. So here we have to come out almost with a no PVL or trace. I mean, regurgitation. Just coming back to the point, natural history of this mild PVL, we know studies have shown that up to 5 years, the 95% will remain mild. Some of them may even regress, particularly self-expanding, and only 4-5% will progress. So we see it, so therefore it's not common that the mild PVL will progress. Mild we leave so many times.
Correct. But I think the issue now is a lot of sites are not doing proper echo, and then actually mild may be actually moderate. But then they were underestimated. Stan, what do you think about that?
Yeah. I think in this case we should aim mostly to seal that origination, origination of the, and less overexpanding the base, the LVOT. Because if you leave the origination like this, and the new valve may again recoil, so the PVL will happen again. So I think the most important is to seal the origin, that is coming out.
We'll talk about that in terms of strategy, right? The procedural strategy.
Good point. So
good
sealing the origin you can do with 23.
Yeah.
But
Exactly.
sealing the bottom for the LVOT, you need 26.
Yeah. I think
Well, we'll show
we
you.
can flare.
We'll
We
see.
can flare at
Yeah.
23.
Yeah, we'll flare.
with
We'll
more
see.
volume.
We'll show you.
I think if we seal that, if we seal it, there will be no PVL, regardless of the.
Okay, so you're saying as long as we take care of the entry point, we don't worry about
There will be no
LVO.
PVL. No PVL.
Yeah. Okay, next slide.
Let's go to our
let's move on.
presentation
Yeah,
now.
let's
So
go
very
do the
interesting,
case.
unusual. So this is the Redo-TAVR CT analysis.
So this is now the current CT. So you can see it's pretty well expanded, but typical of the SAPIEN-3 platform, the mid-frame or the waist is a little bit more constrained. So you can see that here. This is how we usually measure inflow, mid-frame and outflow, whether next slide, and you can see that the STJ is still the same narrow, right? The sinus is the same. You can see this valve instantly is actually commercially aligned on the bottom right picture, so which is good, in terms of the coronary access. And this is from Vinny Bapat's and Miho's Fukui's app. You can see how you look at the Redo-TAVR feasibility. So you can see the CRP coronary wrist plane is where the coronary take off, the lowest one being the left main. And then the neoskirt plane NSP is where the leaflet may get pinned if you implant the valve high. Okay, so we'll talk about where we're going to implant the second valve, but you can see it's right against the top of the left main and the right, and we'll show that thankfully the right is non-dominant here, so it's less worrisome. Next slide.
Otherwise, this could have been a case for having a production of both right and left side.
Correct. So now you can see you punch in the numbers on the Vinny Bapat's app and you come up with a recommendation in terms of need for coronary concern or not. Next slide. So here is what initially what it looks like. I think the lines are drawn a little bit off here. I don't know what happened to the formatting, but we'll show you live. But basically the goal is to put the second valve deeper to try to seal, but still allow some leaflet overhang to preserve coronary access and avoid coronary obstruction.
Okay, want to show it here?
Yeah, let's show the aortogram.
So that's why we show two pictures here.
Fluoro, 1 second, let them come.
But putting the valve deeper will seal the upper part that Kinney was.
Yes.
Okay.
So the first picture is engaging the coronaries from the distance between the STJ and the valve. You see that, Dr. Moreno?
Yep.
And the second is we go through the stent frame. So this tells us that we have reasonable coronary clearance from the STJ, but when you add volume to a 23 and expand, we really don't know how much that STJ is going to be closed off. So it becomes very important that we do not match inflow to inflow here. We actually go slightly deeper.
Yeah, so the idea is to go at the outflow of the next valve at the bottom of the honeycomb, which is the outflow, which is the clear part, because the rest of it have the SAPIEN-3 Ultra, which has already the sealing skirt. So, and you can see the aortogram here. Obviously, severe PVL.
Yep.
You can see that in the other
show me
aortogram
the
as well.
aortogram.
So question is, when you are
Yeah.
doing the teaching point of view, when you want to protect the left main now, you go through the cell or above?
Yes,
Cell.
go through the cell.
Okay.
So AK,
But
can you explain why?
my worry still here is I think the bulky leaflet is the problem. See that?
But we'll pre-dilate first because you need to create a favorable landing zone for your second valve. After your second valve, it's very hard to post-dilate both to expand further. We've seen that. They've done benchtop study on this. So we're going to pre-dilate this to expand this further. And, obviously look at the PVL again, but the idea is to make the valve taller, the overall valve taller, right? So interestingly, for example, the balloon expandable valve in teres is taller. And so they might have increasing the seal zone. It's all about the seal zone in this case.
Yeah, so
how you engage?
Yeah, so maybe Dr. Kinney can tell us what her strategy is for, because this is technically chimney, right? Now, where do you chimney from? From the STJ or from the cell? What do you think, Dr. Kinney?
No, yeah, we have done both, but I think a cell is better if we can.
Yes.
It's just like osteal placement, so that re-engaging is easier.
Yes.
Why we did not choose the newer for discussion part? What's it called? Navitor.
No, this one, well, no, for this one, the second valve cannot be Navitor, but the first valve, I mean, at that time was not available.
No, not that.
Yeah.
No.
No, now no, because then you completely seal off the aortic root. So so the only one, and also self-expanding valve has a less radial force for second valve here for PVL. So the only option here is a balloon expandable valve. In fact, I think all of our cases with PVL issue, balloon expandable has been the answer, especially in failing self-expanding valve, because we had done one recently, right? Not too long ago to help seal the PVL, because self-expanding valve due to the bulky calcium cannot reduce the PVL despite post-dilatation.
Question:
No.
the likelihood of recovering the left main in the Redo-TAVR, is it easier, difficult, or more commonly done than the native TAVR, the de novo TAVR?
Don't know. We'll see it today.
No, but just say the Redo-TAVR will have a high chance of occlusion.
Yeah.
Yeah,
Exactly.
I understand,
Exactly right.
but he's talking about
The recovery.
recovery of left main.
Because the question here will be the chances that we will rupture the annulus with, let's say, a little bit of oversizing balloon valvuloplasty is lower now a year after because it's underexpanded.
Right.
Yeah. So what about using that? I mean, that possibility, protecting the left main, and if we seal the upper part, maybe we will avoid the second valve. The issue is that we have two problems: the PVL that is severe and the left main obstruction. So step-by-step approach. What about that discussion?
So the question is, I mean, this is always there, that if you get a perfect result after balloon dilatation with a 24 millimeter true balloon, as you saw our discussion, we wrote down that we are using 26 millimeter, but the other T analysis, now they felt that 23 will be okay if that's what we are going to do. Go back to the slide presentation. So therefore, I think it's a reasonable.
No, Pedro,
Next slide.
interesting question. Only thing is, it may recoil again, because I think the recoil is because of the bulky leaflet.
Yeah.
So it may nicely respond to our balloon dilatation right now. May look good. After a few weeks, we see the patient again in the office. It may recoil and we may be back to the same situation. So I guess once that we are already here, we should do a second valve despite having a good result with the balloon dilatation. Agree?
I totally agree with Dr. Kinney. We've seen it many times. We post-dilate them and they come back. Remember, recoil also depends on what's outside. And if you have thick, bulky leaflets, it's gonna recoil. I mean, they'll come back in 2 months with same problem, and you end up putting a valve inside. So
we have done a stage approach, actually.
Yeah.
Some of very high-risk patients that redo TAVR. In fact, your patient, Dr. Moreno, if you recall, we actually did a, but then obviously the valve also degenerated, and we have no choice but to do it. And we were quite successful. But you're absolutely right. You don't have to do it at one time. If you worry about that, you're putting a second valve will jeopardize and harm the patient.
Yeah, let's say if we hampered the left main with the balloon valvuloplasty, then we probably wouldn't do a second valve. I mean, just anticipating things in the worst case scenario.
I mean, it
let's-
should
let's
be
move
okay.
on.
Yeah, it was move on because it
Okay,
should be
okay.
okay with the balloon dilatation because you see the white line sign is still quite far now based on our current left main angiogram. So,
Absolutely.
yeah.
Let's do the pre first.
Okay, go back to the fluoro now, please. So you saw
So-
the aortogram. We are going
Yeah,
to cross the
fluoro
valve now.
hemodynamics, please.
Yep.
Can you show us the hemodynamic screen
Yeah,
as
right.
well? Thank you.
No, we wanted to show hemodynamics. 1 second.
Okay, yeah,
We
okay.
put already here.
Let's-
Okay.
let's
done,
There was
done,
no
done.
gradient. I mean, that we knew
Yeah,
by the echo.
we
There
know,
was
yeah,
no
the valve
gradient
was
here.
normal.
Yeah, there was basically no gradient. It was the valve issue. It means it's the PVL issue, not the valve issue.
Yeah.
And actually, you know, a lot of controversy happens that why are we showing this kind of case? Are we showing our failures? No. This is what going to happen. I mean, this is what going to happen. I mean, one time after the initial trial, everybody said that the DES has cured the restenosis with a 0%. Nothing happened. After that, 6 years later, there was a big fiasco, stent thrombosis after DES. So key is, we need to be reality. These things will happen. We need to be better. We need to understand what the issues were so that we all learn and optimize the results at time 0.
I think only a group like you, Dr. Sharma, can do these.
So we're going to pre-dilate first. You can see on the fluoroscopic
Okay, you
scan.
150?
150.
This is the 24 true balloon, correct?
Yes.
Okay.
Cine.
See the
So you see
expanding?
expansion.
Yep.
And a little bit of recoil. You see that?
Yes.
Okay, off,
Okay,
off,
off.
off.
Careful,
Good.
careful.
Yeah.
All right.
Dilate, deflate it.
So
fully.
Stam, want to take a look?
Yeah, yeah. Good. Let the blood pressure
Okay.
come back up. Good.
Okay, can you put please some color?
Okay.
Now,
Okay, put the
Color,
color.
please.
How does it look, Stam?
Gone.
You have a catheter.
more PVL. Look at the.
You have a catheter through.
Huh?
You have a catheter through, is that right?
Yeah,
Yes,
that's, we have
that
a
is
wire.
correct.
We have a wire.
Yeah, yeah.
Yeah, but the area
Is
of
it
the
a- is
PVL
it a
is better.
PVL is better. Do we have
Yeah,
central
pressure is
AI?
low, guys. Blood pressure is low.
PVL is gone.
Yeah, I
Because
told
you
you,
shield-
PVL is gone.
You
Zero.
shield
pace at
the,
80 for now. Fluoro.
Pace at 80.
yeah, it's
Okay.
gone.
Okay.
No, but
T
central
up for a
AI?
minute.
T pro.
No,
T
no,
probe
that's,
up.
I think it's the catheter. You have a catheter through, is that right?
You have a wire.
No, just the wire.
Yeah, it's the wire, yeah.
Okay.
No, no,
So,
that's the wire.
Can
that's
you
the wire.
bring the
Yeah.
T up?
T up, please, Stam.
Yeah.
We need to wire the left main now.
Yeah, let's look at the left.
Give me a
main.
run through and get me my stent.
No, run through wire.
You took that? You took the
Are we
images?
pinning the
You took
leaflet?
images?
Is that why?
We
the-
can pull back a
You
little.
take the images, Prof?
Yes, severe AI.
Yeah, severe AI.
Are we
Forget
pacing at
left main
80?
protection.
Let's see the hemodynamics.
No hemodynamics. One
Can
second.
you see
we
it?
protect- Now also, I think the valve is nicely expanded, almost pancake. Huh? Okay,
Good.
now, wait.
Let's look at the. Let's do a
You're
test.
inside.
Yeah,
Good.
very
No,
good.
am I through the cell? I'm not
You're
through the cell.
You're through the cell.
You are through the
Through
No,
the
I
cell.
don't think I'm through the cell.
Okay,
Why
give me
don't
the
you
run
test the
through.
left main to see what's going on?
Yep, we are doing it now.
Pull back. Give me the
Injector.
syringe.
Yeah, we are.
Pressure getting a little better
Pressure's
now.
better. Good.
Okay.
Yes.
Yeah.
No, he said there was
We're
only
pay-
because
that's-
wire,
that's-
we replaced the wire a little bit and now go forward. Go forward.
Yeah,
Okay, go.
I centered the wire to help as well, just to make sure there's not AI through the wire,
Go.
transvalvular AI, so while getting some
You're good,
time
you're
for them
good. That's
to...
fine.
Looks good. That's reflux.
You take a picture now.
Okay, well, let's just wire and put a stent then. Start cangrelor, please.
For what? You didn't give Plavix?
So you can see one of the maneuvers to get patient out of AI acutely is to pace. Okay, we've done that with balloon valve fracture
Yeah.
before, and also the key you can see here is center the wire.
What's
Sometimes
the
the
strength of
wire
this- what's
pin
the
the
length?
leaflet
Megatron
open,
16
especially normal
photo.
leaflet.
That's right. Yeah. Can we do aortogram
16
here for
onto.
just understanding?
Sure.
So the wire is fixing
So-
one of the commissures, and when you
Correct.
reaccommodate, the
Yeah,
commissure
or
came
the
back.
pin the leaf. That actually was the first Sapien generation.
Yeah.
That was an
It's
issue.
not through the. It's not through the diamond.
Okay, go
We are
back
outside.
in. Go back in then. Rail it on. Go back
No,
in.
no, 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 not that. I think guide is behind.
No, you are through it. No?
You're through. You're through.
Yeah, that's fine. Take it. But can we do, sorry, one audiogram? So if I
We
can take a
did, we
picture.
did.
No, where? Show it. Yeah, now we are doing it.
You're through. You can see the bend here.
And should we put the
So you can see
Godzilla
now,
or
see, you can see now there's less AI, right, on the aortogram. That's why the patient hemodynamics improve now.
Yeah.
yeah, it's nice.
But you see there, despite the 24 true balloon expansion, there's a little bit recoil when you deflate the balloon.
Keep it straight, please.
Δήματσοφ.
Yeah, let's analyze this. What are you seeing here? The line is still there of the leaflet, but leaflet is below the left main, lower surface of the left main.
Yeah. No. So this is just a contingency in case the valve ride up, right? Remember, when you deploy the second valve, you do a very slow
I don't want to
inflation.
place a stent because there will be friction between the diamond and the stent and the risk of us not able to take it out.
If we need to put it, we'll do it.
Okay, fine.
Take it out.
No, but what I want to do, one second.
Because that's the risk of left main closure is very
One by
low.
one. What I want to do, put a stent, see it goes, take it out. Don't leave it. Make sure that it's going.
Make sure you floss. Make sure you floss it.
Floss it.
Good
That's
idea.
it.
So I
Just to
totally
see
wrong.
in case we need, but don't leave it there.
I
Understand?
don't think you need to do that.
No,
Okay?
agree with AK.
Because everything changes once you place the second
Yeah,
valve.
I know. But we want to make sure that
Too
we are
much
in the
metal
right
to metal.
cell, good, no resistance.
Nothing.
Yeah. No, and also we showed that you could pass the guide through the STJ easily. So that's reinforcing the thought that left main will not be that big an issue, but
Or
still
other
makes
could be
sense to
that you
protect.
can leave
Will be-
the guideliner or
No,
Godzilla there.
yeah.
That's another
We don't
part.
need
Key up,
any of
please,
that.
Sam.
Yeah.
It will be easier to
No, but
pull back.
no,
than
your
to
guide has to
advance.
come out first. So what are you trying to do, AK?
Yeah,
Hello?
Yeah.
The guide is into the mid LED.
You just wanted backward flashing. I just did it.
No, not the guide catheter. Let's take the stent guide out a little bit.
Very
okay,
nice.
good. Let's keep it in.
Good.
Huh?
Take it out now. That's fine. But not the guide. We wanted a stent. So we have seen it. The stent will go through even at the top of the leaflet impingement if it occurs. That's all.
Okay.
Okay, valve, please.
Get me the valve, please. 23 plus 3.
Now, yes, the question of if people really want to leave Godzilla, that's not a bad choice. You can put a Godzilla there and keep it. But
So then you
we're not.
are fully protected. Yep.
Yeah, but
anyway,
you know what I'm going to do? I'm going to leave the guide inside. Why
No,
not?
but you can't- you have
At
to-
that
you're
time,
doing
that's okay.
balloon
Nothing wrong with that.
expanded
Yeah.
valve.
So let's very important question. Go to the
It's
echo again
sutured, it's sutured.
from STEM.
Yes.
Any
Yeah, wire,
PVL
wire.
at this time.
Trivial.
Go.
Take it off, please.
So-
2D, bro. Yeah. See,
So it's a mild or trivial?
Trivial. If you see the valve expanded, see, before was a gap. Now
Yeah,
there's
let's
no,
go, guys.
Now there is no gap. See,
Okay.
there is no gap of the valve.
That's what he predicted.
Yeah.
I think the
And
key
put
is
some color, please. Color. And
to-
nothing. That's the central.
Plus, you see just
the-
on fluoro also,
that's
it's
the wire.
nicely
See,
expanded.
Trivial PVL
Beautiful.
there.
to prevent
No, it's
recoil.
not
We
moving.
have to
It's not
be.
moving.
He's going.
We have
Take it
to
up, please, take
fix
it
the annulus. The annulus has to be the one that will
Yeah.
prevent the recoil, not the upper
That is
one.
correct. No,
So if
that is where we
deploying
put a 2
below
millimeter
is-
down.
makes-
Yeah. 2 to 4 millimeter down.
Yeah.
Go.
And then we're done. The risk of occlusion is very low.
I would say that just to be for teaching point of view, if there is any question on this patient,
Stop here.
so you issue about the neurologic
wire.
status, some other status, you want to stop here is okay too.
Yes.
You are kind of obliterated, but we know the story. Some of these patients come back very quickly, and this patient was so frustrated that 15 months later coming back again for the tower. So we want to give the best result and no chance of recoil.
Okay, ready?
That's it. But if
wanna
you
see
want
the
to
arch.
stop it, and we have done that before. We actually, your case, and then we did the live later on when that patient degenerated and came back.
What's your guy?
Keep going.
Okay, wait.
Yep.
Wait, guide coming back. Guide coming back.
Guide is good. No, it's good.
Yes,
going.
yes,
We are
yes,
good.
We
coming.
can
No,
magnify more, guys, so
Wait,
everybody
wait,
can
wait.
see a little better.
Yeah.
Before save
Go
that,
to
please.
15.
Yeah.
Yeah.
Good.
No, we didn't fluoro save.
Okay.
You did?
One
Okay,
second.
so you see the upper diamond. So we have
I guess
like 1/3, 2/3 of that upper diamond.
Get the guidance.
Is
now,
that correct?
what about impinging into the mitral valve if we do too deep?
No.
No, it's gonna
Way
foreshorten.
away.
Okay.
Yeah.
How do you like the position?
I
would-
think, wait, let me go on Cine.
Okay.
Positioning
Pace
is
180 for a second.
Lungs down, please.
Who's going to hold?
Malvin, please.
Okay, go up.
Fluoro.
Cine.
Fluoro. Going up.
No, okay,
Pull up.
pull up.
Yep.
Pull up,
Pull
pull
up.
up.
Push the wire a little bit for me.
Okay, a little bit.
Good.
Don't
Okay,
worry.
good.
You'll be fine. You'll be fine. All right. Nailed it. All right. Sine.
We have to do double.
Always.
Fluoro. Okay, off pacer, off pacer, off
Pacer
pacer.
80.
Don't do anything. Don't do anything.
Pacer
You have-
80.
Pushing, pulling will
Yeah.
create problems.
Just do an
Pacer
Pressure is
80.
good.
The
Yeah,
pressure is good. Just do an angiogram.
I don't think you need it.
The,
With the balloon there, you won't see much.
the LVOT looks pretty nice. Very. Oh, we have a little bit there. But,
Yeah, I want to do one more inflation. Can we go in, please?
Yeah, okay, ready?
but let's analyze this.
No, we have to do it immediately.
First,
There's
yeah.
no-
Base
yeah.
180.
Facing 180.
We're going down. LVOT.
Sine.
Go.
Yeah,
Full,
LVOT is
full.
big.
Done.
Okay, good. Come out. Yes. Don't do
Keep
anything
pacing,
yet.
keep pacing, keep
Yeah,
pacing.
keep pacing. We're coming down.
Off.
We can
Leave
take out the
leave the wire. Get a pigtail.
Yep.
Advance the wire, please.
description.
Good. Blood pressure is coming up. We have a good flaring in the LVOT, which you can see.
And also important is we back to sinus, no EKG changes.
Prof, okay.
I need some help
That's a
with
good
the...
sign.
Yeah, can you? Okay,
Yeah.
ready?
Do the aerogram now.
Yeah.
1 second.
Not
One
yet,
second.
not yet.
Not yet.
I think let's do the hemodynamic, then aortic.
No.
Yeah.
First, let me get
Pigtail?
in. Let's analyze the left main, then I take it out. I take the guide out.
Yeah.
You seal both. Eh?
Take this out.
Then we
Seal
can exchange
both.
with a pigtail.
The area, the origination.
There should be no PVL now,
Yeah,
Stan.
no PVL. No PVL.
Yeah.
T up a little bit, please.
Up, yeah.
Pigtail.
Yeah, good. Let's see.
Okay, ready?
Yeah, go ahead. Go ahead.
Okay, this is something we never thought
Beautiful.
about.
Yeah.
I'm coming out.
Good.
We're
Okay,
done here. Yeah.
remember this is something we never discussed. We kept saying diamond, we kept saying, okay, how we are going to place the chimney if we need, that we will leave it at the ostium of the diamond. Now there are double diamonds.
That's the
So
behind.
if you need to redo it, you have to
the
go
thing
through
too,
the
see?
double diamond and then do the
Seal
stent.
it.
Yeah.
See?
Fluoro.
So I'm coming out.
We may be few
We're done
millimeter
here.
down.
Take it out.
Yes.
I think
Anyway.
Anu's comments were proper.
Take that.
Just leave it there. I need
Keep
to do
going.
hemodynamics and then...
Okay, good. I'm in the ventricle.
Because
All right.
otherwise you will not have that
Let's-
stent expanded. Because this diamond of the second valve will not
Let's
allow
exchange
the
this
first
with a
stent.
pigtail, then we'll
But
do
if you're
a
2 millimeter down,
Explain.
I can do it.
the whole point was that are you 2 millimeter down? It looks like you're
It
2
is 2 millimeter
Where
down.
was
But even then, 4 millimeter
Where was the
megatron
PVL?
is not going to
But you can
achieve.
see
the
the
PVL.
second valve
J
never
valve.
foreshortens the same way as the first valve.
That's true. Yeah.
So
And
we
get me
picked the
another
right
pigtail.
valve by 23.
yes.
26 will be even bigger problem.
A little bit more-
Because you'll be
So
very
that's why I switched.
unexpected.
I
I
said,
agree.
let's use
I agree.
Okay,
So
one at a time. One at a time.
Oh, great. Unbelievable.
Make the points, he's saying one at a time.
You take
So,
that-
Dr. Moreno, what we're telling the audience is that you can see the second valve never foreshortens as much as the first valve.
Can we do 2D, 2D?
You saw that, right, Dr.
Yes,
Moreno and the audience?
yes.
So, and the first valve, you really have to expand like what we did to prepare the second valve for that reason. And you can see now the second valve does have a little bit more flare and the inflow. And that's the whole idea to reduce the PVL. But to do that, you have to pre-dilate the first one. Because otherwise, it's
Stop
not going to
the
be
cannula.
productive.
Got it.
Stop the cangular, please.
Yeah, geometrically, you're putting a valve
Plus,
in a,
but this
in a
patient should get
circular-
Plavix.
Yeah.
No,
Go ahead.
Plavix or anticoagulation SS?
I would do
With the bulky
anticoagulation 3
leaflet and
months.
double
3
valve.
months anticoagulation.
Yeah, that's a great discussion about anticoagulation need after Redo TAVR.
And the bulky leaflet at the
Yeah.
ostium of the left main.
Give me some
Okay.
flashes.
Let's analyze this balloon inflation. We recorded that completely or no?
Yes, we have it.
Okay. Let's see for
Pass
everyone's
wave, pass
sake.
wave.
So this is
Pass wave on the corner. On the,
We didn't record
we
it.
didn't. We didn't.
Extremely slow.
Yeah.
very slow. It moved down, then we pulled up.
Yeah, so the key here is that you have to push the wire to stand the valve up higher, because otherwise the first operator pull, but it's not going to pull
Okay.
in an off coaxial.
Okay,
See how
good,
coaxial this is?
Yep.
If you pull, you're going to pull the valve in a non-coaxial manner.
Okay.
So the only way to
they're
stand the
going-
valve up if it goes deep is for the person
Wire.
to advance the
Advance
wire.
the wire.
Did you do
Yeah.
everything?
It's easier to push than to pull. That's the same thing for mitral valve in valve, same thing for other procedures.
So important point he made. Pulling is not easy because now you have metal to metal friction.
Correct.
You have like a half dilated
show
second
the
valve,
hemodynamics
and the
there.
first valve, metal to metal friction, is not going
You put some color
to
there?
come back easily. So the easier maneuver, if you want to pull back,
Minimum
is
PVL,
for the
minimum.
second operator, advance the wire a little bit. Just a
Let me
little.
get the better
You
one.
cannot be advancing a lot, then it will come back up again. And why did it go down? And we have seen that in other live case also, is the space at the STJ,
Yeah.
like we decided. So we could not keep the guide inside.
There. Okay, take color.
Yeah.
So the other option was to leave the
Put
the T-probe up,
guideliner or
please.
Godzilla.
T-probe up.
Take it, please. Take
What
it.
was it?
Now, if you see there,
Who?
on the inside surface, see that's a gap. That's the new valve is
fine.
below. This about what, 5 millimeter at least?
You want this out first?
Yeah. Okay.
Okay, can we paste, please?
Nothing.
Nothing.
All that you saw was central. The lead
Okay,
valve.
good. But let's go back to. Is there a dissection in the aorta about the
Also, you sealed the origin of the
okay.
PVL.
Let's do the TE.
T.
Aorta looks okay.
Yeah.
Yeah.
Yeah, aorta is.
Not that.
I show
Just at the level of the valve.
Okay, yeah.
Now put the echo on the main screen. We are done with the fluoro. Good.
Okay, good. And PVL is gone.
Yeah. Put color, please. Color. Yeah. Yeah, no PVL, nothing.
No PVL.
Minimal PVL, maybe.
And
minimal.
show me the aorta just above the valve.
Minimal. You take the color off, please. Take the color. Yeah. No problem.
Aorta is good.
I don't see anything.
Beautiful. Okay.
Okay. All right, we'll close up.
Okay. If you say so,
All right.
Okay.
So I think this is a beautiful demonstration of a complex case with more important lot of discussion.
Just take the,
How to get the best result for these. We can go back to the slide while now. What is the next step now?
Just going to close the door.
Just going to close
done
the
here.
Okay. Now, what about, tell us a little more about your mentor trial, which you're doing at present, and which cases are those?
Right. So it's called Access Manta. You all know about the Manta closure system. It's a sandwich-based technique. So we designed this study for appropriate patients based on CT screening criteria that Gilbert, George Dangus, and myself, we wrote down. We are studying it in 10 sites in US and Canada. Out of 250, we have already enrolled 130 patients in last 7 months.
And so far looking good.
Yeah, I cannot share
no,
yet,
no,
but
I'm saying,
yeah,
no,
things
remember,
have been very good.
Yeah,
very
so
good. Yeah.
means nothing remarkable that require any halting the trial or look
Absolutely
into the
not.
safety point
Absolutely
of view. That's what I
not.
meant.
Yeah.
Because see, even today, we are having a discussion of the midpoint of the Protect 4 trial to say the safety point of view, that where we are and so. So let's talk about quickly, next 10 minutes and so, about the recent publication in the TAVR field. And biggest question is about the small versus large aortic annulus. And which one is, we are very well aware of the SMART trial, of the self-expanding versus balloon expandable TAVR with the 1-year follow-up. And then the partner trial data came from intermediate to low risk patient and a 5-year follow-up. Then there is a landmark trial comparing my valve with the other expanding valve, self-expanding and balloon expandable. Then commissural versus coronary alignment during TAVR came from Mount Sinai, and the cardiac damage and long-term outcome post-TAVR. So first one is the SMART trial, which we presented last episode 2 months ago, which compare a small annulus, basically of less than 430 millimeter square by MDCT, and randomized to self-expanding versus balloon expandable. So about 700 patient trial, 716. As you can see that on the left side, 1-year outcome, clinical was identical. On the right side, bioprosthetic valve dysfunction is much higher with the balloon expandable versus self-expanding, and pacemaker, of course, was higher with the self-expanding valve, which was expected. And all the hemodynamic parameters were superior in the self-expanding valve compared to balloon expandable in terms of mean gradient, effective orifice area, hemodynamic structural valve dysfunction, and so. So everybody, and moderate to severe prosthetic mismatch. So everybody thought that now this is the end of the story with the small valve, balloon expandable valve, as you know, at present is the bigger market share. And how we are going to interpret these data with expanding, which have been used our balloon expandable for so long. So key was, so what these people did, the question remained after that is main question was, looks good at 1 year hemodynamics, there was no difference in the clinical outcome. Then what does it mean in terms of the comparative valve efficacy at the long term? And long term, basically, we say at least 5 years and plus. So what the partner group did, very, I would say innovatively, that let's take balloon expandable data in the small versus large annulus. So what they did is not just the small annulus, and they'll show the small annulus data later. But let's see what is the importance of the small annulus versus large annulus. 430 versus more than 430, and you can see 1/3. 1/3 are small annulus, what we do for the TAVR valve in the intermediate to high, the low risk patient. And clearly what happened? With the large annulus, you'll have a lower residual gradient and so on and so forth, and there's not much difference others which can be seen here. Now, patient prosthetic mismatch will be same, that you'll have the less in the large annulus versus lower annulus. Now, but what does it all mean? So that's it, clearly the mean gradient. Large annulus will have a lower mean gradient, and so most important is this slide. Small versus large annulus. The way we do balloon expandable all-cause death at 5 years is identical, 29%. So you say yes, hemodynamics are better with the large annulus, but as far as the outcome is concerned, is identical. And now if you take other endpoints of the all-cause death, disabling stroke or heart failure readmission, identical 34%. So therefore, what does it mean? Yes, large annulus will have a different hemodynamics, but as far as the clinical endpoint, was no difference in small versus large annulus. Then aortic valve intervention, again, no difference. As you can see there, biprosthetic valve failure, BVF, at 5 years, small versus large annulus, no difference as shown in the trial, and same is the quality of life in survivors. Clearly, with a small versus large annulus, all do quite well at follow-up. So basically what it seems to be that, yes, it looks very good, hemodynamic point of view from the SMART trial, that in the small annulus, self-expanding valve got a better hemodynamic, but will it translate into the clinical outcome need to be seen. But if we can get the data of the partner trial with a balloon expandable, answer was none. Now, second point was, now take the small annulus, where you left the gradient of less than 20 or more than 20. That was one of the endpoint was in the SMART trial. So as you can see, about 11% of patients will have a gradient of more than 20, and 89% has a gradient of less than 20. So what happened in the small annulus with the gradient? And you can see here, no difference, identical. So just to say, whether you left in the small annulus, you'll leave some gradient, but it will not translate into your death or disabling stroke or heart failure readmission. And this is the valve. In reintervention also no difference with that less than 20, more than 20. It's a 5-year data. You say, well, maybe things will change in 10 years. Maybe, but that's what we have right now. Then patient prosthetic mismatch, that we know. Anytime you have patient prosthetic mismatch, higher the severe PPM will have a higher event rate, 30 versus 44, but that is for any kind of valve. So therefore, what was the implication? I would say clinical implication basically is that 5 years outcome for severe AS patient received a SAPIEN-3, excellent irrespective of the annular size. Despite a small annulus patient having higher gradient and raised of PPM at 30 days, there is no impact on 5-year clinical outcomes of valve durability in BV, in balloon expandable valve. And valve intervention was identical. So therefore, I think what we learned basically is that it looks good from the hemodynamics, but whether it will translate, we only will have the data of the SMART trial at follow-up. Now then the landmark trial was the My Valve. Actually, I was the first, did first 5 cases back in India, introduced into the Indian market first. And of the first 100 cases, we did 32 at my hospital in Jaipur, ESCC. And now this valve is used quite well in various countries besides India, also many places in Europe, France, Italy, South America, and so. And they went to the comparing the My Valve with the balloon expandable, existing balloon expandable or self-expanding valve. So basically procedural details are about similar, and these were the 30-day endpoint, and the primary outcome of the landmark trial was the 30-day endpoint. And you can see non-inferiority, 25% versus 27% of the My Valve versus contemporary transcatheter heart valve. And rest of the outcomes are exactly identical with a moderate to severe PVR and major vascular complication and conduction disturbances. So identical in terms of the 30-day endpoint. So only 30 days, whether it will make a difference in 1 year, there have been some data. Now, we did see slightly better effective aortic orifice with the My Valve region is they are available in the intermediate sizes. It's available in, we are 23, 26, they are 24, 24.5, 25. So various intermediate sizes are available that made to a slightly better EOA, but not significant, but slightly better. And this is the 30-day endpoint, and individual endpoints as shown on the right side were identical, so no difference. So just to say, there is another valve. So, you'll say, well, so what? We got another valve, but means what? I think one of the biggest thing is the cost. So in India at present, of the 400 TAVR done per month, my valve has a 50% of the share, between 50 to 55, and the valve cost is half of our FDA approved valves. So this is great for the developing countries, I would say for India, which has really made this this valve possible into a general population. Before the my valve, we are using about 70, 80 valves TAVI per month, and now it's about 400 plus. And one of the cost is the big important advantage. Then this is a paper came out from here, commissural versus coronary alignment to avoid coronary overlap with the transcatheter heart valve commissures in TAVR, CT simulation study with Manish, which were our hybrid structural and coronary fellow, and they had done the alignment, a lot of CT simulation, trying to see that cusp, whether coronary overlap versus what we know about the commissural alignment. So maybe Gilbert or Sahil can make a point that why do we worry about the coronary overlap?
Yeah, no, I think this is a very important point, because we always have spoken about commissure alignment, right? And commissure alignment, yes, God has made commissures for a certain way, but the arteries might take off in a different fashion. So commissure and coronary alignment are absolutely two different concepts. So should we aim more for coronary alignment? Should we aim more for commissure alignment? I think the jury is still divided out there. I think Gilbert sort of introduced the concept of commissure alignment, but he feels pretty good about coronary alignment as well, and let's see what he thinks.
Yeah, so this study basically looked at almost 2,000 CT to see, how often do we need coronary alignment. And the answer is rare. If you look at the central figure and the next slide, the graph,
this is it.
Basically the only time you need to coronary alignment that might help helpful is with the right coronary, because it's more variable. It's only 2.97%. Most of the time you don't need it. So I think the whole concept is that most of the time commissure alignment will be fine. It's definitely important for younger patients, especially Redo-TAVR, for coronary access. And you can see this patient had the commissure been misaligned. This patient coronary access will be very difficult after two valves. So the bottom line is don't worry about coronary alignment unless you need to, and most of the time you don't need to.
And then just to say, knowing that the Evolute FX Plus has come,
that's right,
to see with having the coronary alignment, so that we have coronaries originating from those dedicated cells. What is the impact of FX Plus based on your observation of this?
That's a great point, Dr. Sharma. The FX Plus, just like any surgical valve or any transcatheter valve, the commissures and the things are only 120 degrees apart.
Right.
So the cells are also 120 degrees apart. So as long as your coronaries are within 120, maybe 130, 140, you should be fine. But once you have more effaced coronary, like 150 or more, then it's not going to be helpful. And so right now we're working on a project together when we're trying to look at what is the change in orientation that can still have coronary access.
Because the biggest challenge still is the RCA.
Yeah.
It's not usually the left, it's the RCA.
Yeah, because anterior takeoff, on false view, and so forth. So.
Okay. So same thing is, basically just to say we need to learn quite a bit, and this has been shown already. So basically using CT simulation, the incidence of coronary overlap with transcatheter heart valve commissure is rare. With commissure alignment, coronary alignment reduce right coronary overlap, where the commissure alignment had higher rates of no left coronary overlap. Coronary alignment should be reserved only when commissure alignment results in severe coronary overlap. So basically, as you said, it's usually not important.
Right.
Basically, great study, nice publication, but basically means not important. Yeah.
Yeah.
Okay. So then the last one, I just want to put it together, the issue about the cardiac damage, non-aortic valve. Damage to the heart, you remember the various stages of the myocardial damage is coming up, that you do a nice TAVR case, but then these patients continue to have trouble. This is another publication from the Swiss TAVI registry. We have a stage up to 0, 1, 2, 3, and 4 based on the various myocardial damage, and basically showed the same what we knew. that outcome are dependent on where your myocardial damage was. So basically, they try to get early rather than wait for the myocardial damage and they do the TAVR. And I think this, to me, the extent of extra aortic valve cardiac damage before and after TAVR and change in cardiac stage early after TAVR have important prognostic implication during long-term follow-up. So I think this probably can make a point that maybe you should intervene early. So this is just to show up our take-home message is that SAPIEN balloon expandable valve with long-term data at 5 years and the partner trial failed to show any mortality, other clinical outcomes, quality of life parameters, or AV reintervention or bioprosthetic valve failure between small versus large annulus. So therefore, basically, yes, those are good hemodynamics, but not really translate into a clinical outcome. In the small annulus group, low 30, less than 20 or more than 20 residual gradient did not impact 5-year clinical outcome. Therefore, positive valve hemodynamic outcomes from the self-expanding valve or balloon expandable noted in the SMART trial had to be interpreted with caution as to the clinical efficacy of two valves because it has been shown very well in this 5-year follow-up. New balloon expandable my valve is comparable to current generation, and I would say it's kind of a boon for the developing countries because of the lower cost. Then the recent CT simulation studies added to our understanding of the commissural versus corneal alignment, that corneal alignment is rarely needed, as we have said it. And lastly, the recent report from CIS-2IV registry reinforced the impact of the cardiac damage pre-TAVR in long-term outcomes after TAVR, hence making the case of early TAVR in life history of moderate to severe AS is probably prudent. Now questions, the following statement not true regarding the outcome of the small versus large annulus in the partner trial up to 5 years, similar mortality rate, similar stroke rate, higher BVF rate in small versus large, and higher residual mean gradient post-procedure in small versus large. Clearly, the higher BVF rate is wrong because it was identical. Second, following is not true. Outcome at 30 days noted in the landmark trial of the my valve versus other, similar mortality, similar stroke rate, significantly higher EOA with my valve versus other, similar PVL, no. The slightly higher EOA, 0.606, but not significantly different. The last one, the following results are true regarding the impact of commissural and corneal alignment on coronary overlap during TAVR CT simulation study, except severe corneal overlap is rare with commissural alignment. Corneal alignment reduces the incidence of both RC and LC overlap. Corneal alignment reduces the incidence of RC overlap only. No corneal overlap for the LC is higher with a commissural alignment than corneal alignment. So B is wrong. Corneal alignment reduces the incidence of both RC and LCA. No, it's basically for the RCA. So with that note, we conclude our today's presentation.
Very good. Well, thank you so much for the heart team and the structural team for this extraordinary case. Remember, these cases, as well as the other ones, can be seen this afternoon in our website, ccclifecases.org. Structural heart life cases occurs every other month on the second Tuesday at 9 a.m. So the next one will be September 10, second Tuesday at 9 a.m. Enjoy the rest of the summer and see you then. Thank you so much.
We have coronary every month, we have peripheral every month, they're asking for structural every month, so maybe not September, we might do it in August, but it's a work in progress, which I call it WIP.
No, not in summer, not in summer, people are not around.
All right,
Dr.
thank
Kiri.
you.
Nothing, yes.
Okay,
Thank you, bye-bye.